Post-traumatic stress disorder, also known as PTSD, is a psychiatric disorder that occurs when someone experiences or witnesses a traumatic event like a natural disaster, an accident, war, police contact, or sexual assault. According to the American Psychiatric Association, people who develop PTSD can encounter multiple kinds of symptoms, which fall into these four categories: intrusive thoughts, avoiding reminders, negative thoughts and feelings, and arousal and reactive symptoms. Not all people who experience trauma can develop PTSD. Contrary to popular belief, anyone can have PTSD. It can appear in people of any race or ethnicity, age, culture, and regardless of their life's experiences. Women are twice as likely as men to have PTSD. In modern times, the disorder became famous as shell shock during World War I, and up until the 1980s, when the disorder was added to the DSM 3, PTSD was only used when talking about the experiences of war veterans.
To further investigate this issue, we looked into several different journal articles. The first one being Racial and Ethnic Differences in Exposure to Traumatic Events, Development of Post-Traumatic Stress Disorder, and Treatment Seeking for Post-Traumatic Stress Disorder in the United States by Robertson et al. This article used data from the National Epidemiologic Survey on Alcohol and Related Conditions to look at racial and ethnic differences in lifetime prevalence of PTSD, exposure to 22 potentially traumatic events, and development of PTSD. The sample consisted of 58.2% white people, 19% black people, 18.4% Hispanic people, and 2.8 Asian people, with an 81% response rate. The results of the article show that white people had the highest exposure to traumatic events in general, with the main traumatic event being unexpected death of a loved one, whereas the main traumatic event for Black and Hispanic people was exposure to child maltreatments, assaultive violence, and domestic violence. The article also found that the risk of developing PTSD was highest among Black and Hispanic people, and that Black people had the highest lifetime prevalence of PTSD, which you can see from the graph on the left that shows that Black people have 8.7% and white people have 7.4%. And as you can also see from the graph, Asians had the lowest percentage in every category. Lastly, all minorities were less likely to seek treatment for their PTSD than white people. White people were 53% likely to, Hispanics 42%, Black 35%, and Asians 33%.
In an article titled Racial Ethnic Differences in the Impact of Adverse Childhood Experiences on Post-Traumatic Stress Disorder in a Nationally Representative Sample of Adolescents by Jennifer Elkins summarizes that there are many aspects that play a role in the increase of PTSD, such as socioeconomic status, environmental resources, discrimination, racial socialization, and coping style. Being a member of a historically marginalized racial and/or ethnic population increases the risk for negative physical and mental health consequences due to the adverse childhood experiences, or ACE, which can be caused by the disproportionate burdens of being in that oppressed group. According to the study, African Americans and Hispanic youth exposed to ACE also contend with the interlocking influences of racial socialization, racial stress, and racial appraisals. These adverse childhood experiences could include sexual, physical, and emotional abuse, and the most prevalent, neglect. As you can see in the graph, Black and Hispanic adolescents have a much higher rate of ACE than the other groups that were tested. The higher ACE score was associated with increasing odds of lifetime PTSD. This data is due to the perceived discrimination and racial stigmatization of African Americans and Hispanics, which has also been linked to the increase of PTSD.
A person is not more likely to develop PTSD just because of their racial or ethnic background. However, it seems as though that being from a minority group is connected with an increased likelihood of having PTSD. Although some researchers have found that people from minority groups are more likely to develop PTSD after a traumatic event, this does not seem to be solely about a person's racial or ethnic identity. Instead, people from some minority groups may be more likely to have characteristics or risk factors that increase the likelihood that they will develop PTSD after a traumatic experience. One of these risk factors can be contact with police. Statistically, people of minority groups come in contact at higher rates with police compared to white people. This is due to the institutional racism and criminalization of Black and minority bodies. In Amanda Geller's article, Police Contact and Mental Health, the risk factor of coming into contact with police is taken into account and analyzed in correlation to the occurrence of PTSD or PTSD symptoms. Since minorities, especially Black people, have more contact with police, this risk factor is racialized, and investigating it gives us insight into the effect of race on PTSD. In the study, PTSD was measured by using a checklist of 9 items from the Impact of Events scale, which identifies symptoms that respondents report associated with a particular critical event. The respondents were also asked to recollect events in which they encountered police and how critical they were to them. The results show that the total number of stops respondents reported was negatively associated with PTSD. The opposite direction of recent and lifetime stop quantity in their respective associations with PTSD suggests a potential moderation of symptoms for respondents with long history of contact with the police. This interaction suggests a moderate relationship between the quantity of stops experienced and the subsequent PTSD symptoms. Furthermore, there was a statistically significant association between the stop quantity and intensity and PTSD. We found that some evidence of increased PTSD symptoms for respondents that reported more intrusive and intense critical stop. Some of the respondents were stopped 18 times or more. However, the results do not indicate systematic difference in average symptoms between levels of highest and lowest quantity stops.
In an article published by Directions in Psychiatry titled Assessing PTSD in Ethnic and Racial Minorities, Trauma and Racial Trauma, 4 psychiatrists looked at how ethnic and racially motivated traumatic events can cause PTSD in people of color. Unfortunately, this type of trauma is often not identified during clinical assessments. They find that there are many factors that can cause the disparity between races. These include, and aren't limited to, overt racial slurs and threats made in any environment by anyone, police harassment, body searches and assaults, workplace discrimination, community violence, distressing medical experiences, incarceration, immigration difficulties, and deportation. They also created distinct definition for racial trauma, which is a traumatic response to race-related experiences that are collectively characterized as racism, including acts of prejudice, discrimination, or violence against a subordinate racial group based on attitudes of superiority held by the dominant group. Racial trauma can be caused by overt or covert actions carried out by individuals or society. Black and Latinx populations in the United States appear to be at greater risk for PTSD than whites, whereas Asian individuals appear to be less likely to develop this disorder. Estimates of trauma exposure among racial and ethnic groups are mixed, although people of color appear to be at greater risk for trauma related to maltreatment during childhood, immigration issues, war, by witnessing domestic violence. The expression of symptoms may also vary by race or ethnicity. For example, African Americans with PTSD may demonstrate a more negative worldview with less heightened arousal than others, whereas Latinx patients may demonstrate physical symptoms and avoidance more often than members of other ethnic groups.
To solve the issue that we have described, we are providing the following recommendations. We should give equal access to healthcare and treatment options to all people of all races, regardless of their socioeconomic background. We should also start at the root of these problems, such as improving social service and putting children in safer homes so they do not experience risk factors. Or we should stop the cycle that pushes poor people into the military, which causes them to experience PTSD, which then leads them to not being able to move up the social ladder. We should also have a large-scale shift in our social consciousness by raising awareness and understanding the toll that these impacts take on the psyche of victims so that even small acts of racism become unacceptable. We need those who witness racism to speak up and speak out, and victims to be believed. We also should decrease risk factors for minorities by deracializing the issues, such as police contact.
Here are our discussion questions.